on tendon transfers. The last time I looked at the poll, it looked like we were, again, maybe half and half between medical providers of different specialties as well as parents and families. And so I will try to incorporate both perspectives into this. I looked at the poll, it looked like we were, again, maybe half and half between medical providers of different specialties as well as parents and families. And so I will try to incorporate both perspectives into this.
Window.
Can you, is that better now?
Yeah, now you're not, yeah, I think.
Okay.
Yes.
I had the stage open.
That's probably what was doing it. So.
Sorry, everybody. So we will move on here. So I'm going to, this is mostly for the family perspective, review some basic principles.
Sorry, do you mind sharing your slides again?
Oh, did that not work?
Yep.
Sorry. This is after we did the practice.
I know, it's okay. There we go, perfect.
All right, objectives, here we go. So we're gonna start with basic principles that, what is a tendon transfer? What is a tendon? We'll go over that. And then understanding why we might decide for or against this type of operation and some of the examples that might be helpful for children with AFM. So to start with, a tendon is what connects the muscle to the bone. These are long, narrow bundles of tenocytes made out of type 1 collagen, and the rest is made out of type 1 collagen fibers. And the tendons are what allow us to have such incredible movement in our muscles. And so if you think about the combination of wrist and digital flexion, those flexor tendons actually move a combined 9 centimeters over the course of closing and opening your hand. They also can withstand incredible strength, up to 120 newtons. So, an apple falling off of Newton's tree is 1 Newton, up to 120 newtons when we make a tight pinch with our index and our thumb. So really incredible properties, and a lot of what drives movement and strength in our arms and legs is from the properties of tendons. The way that tendons heal is different than nerves and different than bones, and this will play into how we do the surgeries and how we rehab the surgeries. And so just to review this a little bit, in the first few days after a tendon injury or a tendon surgery, we have an inflammatory stage. And during this, the strength of the repair is entirely dependent on the sutures that we've placed after the surgery. Following that, the tendon will start to repair itself, and that process takes about 4 weeks. The tendons make both fibroblasts and collagen, and they actually have a loss of strength because there's some disorganization during this time period. And then after 3 weeks, the strength increases rapidly. And so as we'll talk about later, after a tendon surgery, we would require immobilization for a period of time to allow this process to take place. And then remodeling of the tendons back to a nice linear fashion will take up to 4 months. And so certain activities might be prohibited after a tendon surgery for 3 or 4 or even 6 months to allow this remodeling process to take place. So we'll get back into that after the surgeries, but I thought it was just a good overview of what a tendon is. And so a tendon transfer is quite simply when we take the tendon insertion from one location or one bone to another. And so the muscle now performs a different function. It has its same muscle belly, it has its same origin, but it's simply acting on a different part of the body. The innervation of that muscle stays the same. It's just pulling on a different lever. And so this is sort of, orthopedics at its best and most simplest. So when might you do a tendon transfer in a child with AFM? And so quite simply, this replaces the function of a nearby denervated muscle. So you have a muscle that does not have adequate nerve supply, a muscle that is weak and an important one, and you want to replace its function. If there's something nearby that can be transferred over, then that would be an indication for a tendon transfer. You're going to hear a lot about nerve transfers in the next session. This is an example of a classic Oberlin type nerve transfer that you'll hear more about, but we don't always have available nerve transfers. And as Riley talked about earlier, some people don't have access to specialists in the first few months when we would recommend nerve transfers to be done, or maybe a child is too sick. Maybe we're not sure whether something would be necessary or appropriate. And so once we've gone out of that window of nerve transfers, we can still do tendon transfers if there are available tendon donors. And then finally, the rehab for tendon transfers is often more reliable than nerve transfers. As we're just waiting for the tendon to heal, we don't have to wait for any type of neurologic connection to be remade. We're just waiting for the tendon to heal to its new location. This is a great for the, now switching to a more medical side of this. So for the surgeons and therapists and neurologists that are in attendance, this is a great article out of the group in WashU that perhaps Dr. Moore will tell us whether there's been some updates to this, but this was from about 10 years ago, talking about what the options were for nerves versus tendons, and how sometimes a nerve transfer in a given situation might be preferable, and sometimes a tendon transfer. And so this is a really great review article on that, giving us lots of options. So the principles for tendon transfers, we need to have a supple joint. And so this is where rehab can be helpful, even ahead of a planned surgery, that we don't want to have any joint contractures. If there's a contracted joint, the tendon won't be able to pull against that. And so we need a supple joint. We need an expendable donor, and that donor has to have good strength. So although it may have been previously denervated, we want it to at least have some strength against resistance, or what we call 4 out of 5 strength. We typically lose a little bit of strength in the transfer of a tendon, so we want to make sure we're not going to lose too much. We like when tendons have synergy in the transfer, and so an example of that would be that wrist flexion and finger extension tend to go together, and wrist extension and finger flexion tend to go together. And so we may transfer something, so one of those to another one of those, in order to take advantage of that synergistic effect. And then because this is simple mechanics, a straight line of pull is really best. So there are some tendon transfers we do, and that I'll show you, where we make a turn in the direction of the tendon, but they really work best with a straight line of pull. And again, because we want to keep things as simple as possible, it's best to ask a muscle to only do one function. And so sometimes when we are in a bind, we may try to use a tendon transfer to perform 2 functions, but they really work best with a one muscle, one function kind of principle. And then in terms of what the tendon will be able to do once you transfer it, the work of a tendon is made up by the force and the amplitude of the muscle. Force is proportional in muscles to a cross-sectional area. As an example, the quadricep muscle in your femur has a big cross-sectional area and can do a lot more than your EPL. And so you would not want to, use one of those to replace the force of the other. The muscle bulk should be about the same from the muscle that you're transferring to and from. And then this curve here is the Blix curve in muscle physiology, just showing that the greatest force that a muscle has is when it's at a resting length. So for surgeons, it can be very tempting when we sew in a tendon transfer to try to keep it as strong as possible, make it as tight as possible, but really the muscles work best when they're at their natural resting length. And then amplitude is proportional to the excursion of the tendon. So like we talked about in the hand and wrist, there's a lot of tendon excursion. In other parts of the body, maybe not so much. And so again, we want those to be proportional when we think about what are appropriate tendon transfers. In the age of telemedicine, I think it's been very challenging to figure out what are things that we should be doing over the computer and what are things that really need to be done in person. For me, this type of assessment really is something that needs to be done in person. We want to find out which muscles are lacking, which muscles are working, and particularly how well. What is that strength really? And that's something that really I can feel best with my own 2 hands. And then is the patient's recovery still ongoing? And is the patient willing and able to rehab and retrain their muscle function? Again, in the pandemic era, are they going to be able to get good physical therapy? Are places open when they come out of their immobilization? It's time to start therapy. Or is there going to be someone to work with them to help them do this? And is the family and the patient ready to go ahead with that? Most of this is done by physical exam, although certainly we can get an assessment of muscle size and bulk on MRI. EMG and nerve conduction studies can help us to understand the state of denervation. And so sometimes those adjunctive tests are useful. But overall, I think there's really no substitute for an actual patient assessment in person to understand the strength of those muscles. And then, as you will hear, in our several sessions on nerve transfers, once you understand and follow the basic principles, there are a ton of options that have been described for tendon transfers. And so once we know what our goal is, we can think about all the different nearby muscles that might be recruited and where we would put those to function. And so there are really way too many of these to list. These are just some of the more common examples. And I'll go through some of the most common ones in some more depth. So I think overall, the most common tendon transfer that we do in AFM is probably also the one that is best replaced by a nerve transfer, unfortunately. And so this would be the trapezius to deltoid transfer. The trapezius is a large muscle in your back that we can use to kind of extend into the shoulder and substitute for the function of the deltoid. The denervated deltoid is very challenging. This is a common problem in AFM. Some children may be candidates for nerve transfers to restore the axillary nerve. But again, there's lots of reasons why people might not be a good candidate for a nerve transfer based on timing or other muscles that are affected. And so sometimes we may want other options. The difficulty with the deltoid is that when the deltoid is not functioning, that also leads to instability of the shoulder. And when the shoulder is unstable, it then hampers the ability of the other muscles in the arm to work. And so this is an example of a patient that did have preserved trapezius. You can see he's able to shrug that shoulder up and preserved external rotation, but really can't get the arm away from the body because the instability of the shoulder from the denervated deltoid means that the other muscles around the shoulder can't get coordinated to work and lift the arm up. And I apologize to the parents for any graphic photos, but just to show, this is quite a large surgery. So the patient's head is at the top of the screen here, and then this muscle on the left side of the screen is the trapezius that has been elevated and prepared for transfer. And then here it's been tucked down under the deltoid with the deltoid sewn over it so that it can assist with the function of the deltoid. Following surgery, the patient, like I talked about at the beginning, this whole shoulder then needs to be immobilized. And you can see there the shoulder joint in a much better position, but the whole shoulder being immobilized in a brace, typically for about 6 weeks following a surgery like this. The difficulty with this surgery is that these are both big, large muscles, but the trapezius did not have the excursion that we would like to adequately substitute for the deltoid. And so we tend to get good stability out of this operation so that the other muscles of the shoulder can work well, but we don't tend to get overhead, true overhead deltoid function out of the trapezius with this tendon transfer. So it can be helpful, but it's not a home run. And so this is one where we would personally really advocate for nerve transfers if they're available to replace the deltoid function, and the trapezius really more as a second option. The next example is a very successful tendon transfer, but one that is actually not very commonly an issue in AFM. So this is the latissimus to rotator cuff transfer. The rotator cuff is powered by the suprascapular nerve. So if that is denervated, then a patient will lose external rotation. If there is preservation and reinnervation of the deltoid, the patient will be able to lift their arm up, but not while their arm is in towards the body, because they won't have that external rotation of the shoulder. This is a very common situation in children with brachial plexus birth injury, which is a condition that many of the people speaking here today also treat. But it's actually a combination that for whatever reason is rare in AFM. And so for this transfer, this is showing the latissimus and teres taken off of the anterior aspect of the humerus and then sewn into the posterior aspect of the humerus up under the functioning deltoid. These are in some photos. This is typically done through an axillary approach. Here's the tendon being taken off of the anterior aspect of the humerus and then sewn underneath the deltoid on the posterior aspect of the humerus. And here's a child who, before the surgery, was not able to bring that arm away from the body, and afterwards he is, showing the restoration of that external rotation function. Moving down the limb, wrist extension can be limited or denervated if C6 and C7 are denervated, or perhaps something that extends down the radial nerve. Fortunately, wrist extension is a function that many tendons either already do or can take over. So there are many possible donors when wrist extension is an issue. And as I was showing you this kind of synergy before, having wrist extension improves your finger flexion through what we call the tenodesis effect. And so if a child has has difficulty with wrist extension, they also will have difficulty with grip, and that can be really challenging. And so simply by extending the wrist, if there is some finger flexion there, that allows the finger flexion to be stronger. But you need to be able to then open your fingers in a neutral wrist position. So some children who are more profoundly affected maybe need that wrist flexion to help them open their fingers up. And so there is a little bit of trial and error in terms of therapy and splinting ahead of time to make sure that this is an appropriate procedure to go ahead with. But there are many things around the wrist, and I'm not going to get into all of them, that can be used to augment wrist extension. And then I do want to also touch on one more transfer. The opponentsplasty is adding strength to the thenar muscles in the thumb. And I have seen some patients with AFM that are affected more distally, such as primarily in the hand. So although it's more common for patients to have proximal weakness and have primarily shoulder difficulties, there are some patients who are affected more distally. And I want people to keep in mind that the tendon transfers can really be a great option for the hand. There are lots of possible donors. There's just a lot of muscles and tendons that function down at the hand. And for these more distal issues, we can often see a faster and more reliable recovery from a tendon transfer than from a nerve transfer. It also allows us to follow a patient over a longer period of time before acting, as these distal muscles can show recovery over a period of 1 or 2 or even 3 years. And we don't have to jump the gun when we're considering a tendon transfer. We know that option is always going to be there for us. And so we don't have to feel a time pressure that we feel with nerve transfers. So someone could have a denervated abductor pollicis brevis, which is the main thenar muscle, from a C8 or T1 injury or from a distal median nerve injury. And doing an opponentsplasty for those patients will improve pinch and grip strength. And what we hear most commonly from our children is writing fatigue. So they will often come in saying, yeah, you know, he does fine with all his sports and everything, but he just can't keep up with the essays in class, or he can't finish his homework in one sitting. And this can really help with that kind of issue. This is an example of one. Again, I said, you know, it's better when there's a straight line of pull, but this is a tendon transfer using a flexor from one of the fingers, where we actually have to make a pulley at the wrist to change the line of pull of the tendon. But here you can see an FDS opponentsplasty being sewn into the base of the thumb there. And then these are some beautiful drawings from Dr. Littler, who's a famous hand surgeon who did a lot of drawings showing the EIP being used for opposition, Huber, which is the abductor digiti minimi, and again, the FDS. So all of these things can be used to replace the function of the thumb. And so chances are there is something that's available that we can use to transfer to improve that strength. In general, in terms of what to expect if you have a patient or a child who goes through something like this, as I talked about, the repair really is dependent on the suture in the beginning, and so we need immobilization. So kids will be in a cast or a brace or something, keeping them totally immobile at the affected area for about 6 weeks to allow that healing to take place. Following that, we may do some part-time immobilization along with therapy to strengthen the transferred tendon. Sometimes NMAS can be used to activate the transfer tendon and to help the child learn how to activate it better. And then we want to protect against passive stretch in the opposite direction of the tendon, of the transfer tendon, to make sure that it doesn't get too stretched out. And as I said before, things like sports would not be resumed for 3 to 6 months to allow the proper healing and remodeling. So just to review, the plan here was to review basic principles of tendon transfers. So the work of a tendon is proportional to its force times its amplitude. So we want to look for a tendon that has a similar force and amplitude to transfer. The donor needs to be expendable, and it's best when we use one muscle to replace one function. In terms of indications and contraindications for tendon transfers in children with AFM, if there are no available nerve transfers or it's too late for nerve transfers, we may choose tendon instead. And there are some cases, such as with the opponentsplasty, where the tendon transfer gives you a more reliable rehab. Certainly for all of these, the rehab is quicker because once the cast comes off, it's working. And then as hopefully I showed you some examples that were helpful in terms of how these tendon transfers might be applicable for the patients with AFM. Thank you very much. I have my email here. These slides will be shared as well. Certainly happy to answer any questions in the panel as well as offline. And then next we will be going on to Dr. Sponseller. As you heard earlier, he is a professor of orthopedic surgery, very well known as the chief of pediatric orthopedics at Johns Hopkins, and I'm looking forward to hearing his talk.